Okay, so in terms of investigation of atrial fibrillation, the main reasons for investigating AF is firstly to confirm the diagnosis based on an ECG, also to assess um, the rate, whether the patient's got adequate rate control. This is sort of with the ambulatory 24-hour ECG monitoring. And secondly, to look for any underlying causes or any concomitant diseases. So I would say pretty much every patient would need to have an echocardiogram, uh, partly to look for any evidence of structural heart disease, or also to look for any evidence of LV systolic dysfunction, because if you've got inadequately controlled AF, that can cause LV dysfunction, what we call a tachycardia cardiomyopathy. In some cases, coronary angiography may be required to exclude coronary disease, um, but that's more for the cardiologists really to arrange. But everyone else really should be able to assess, electrolytes, thyroid function, look for signs of any infection, etc. So, in terms of the management of atrial fibrillation, now this is the part where you sort of get yourself into gear. When you come across a patient who has atrial fibrillation, what goes through your mind in terms of what you need to do? So the way I go about this is I split it into three main areas. Firstly, uh, and possibly the most important is to think about stroke prevention. So assessing the stroke risk, working out whether this patient needs to be on anticoagulant, and initiating it as appropriate. Secondly, to think about whether or not you go for a rate versus rhythm control strategy, and I'll talk a bit more about that later on. And thirdly, to look for any signs of any concomitant disorders or any precipitating factors that can be addressed and treated at the same time. So when it comes to atrial fibrillation, obviously one of the biggest concerns is the risk of stroke and thromboembolism, which increases with atrial fibrillation. And there are a number of ways to assess risk, and probably the simplest way is to use the CHA2DS2-VASc stroke risk, which is pretty simple to use. There's um, sort of seven points that you look for, um, which each of these factors increase the risk of stroke. The more you have of them, the higher your risk score. The maximum number of points is 9. The higher your risk of stroke is. If you add them all up and you've got a score of 1 or more in a man, then oral anticoagulation is recommended. Um, if you have 2 or more for a woman, then um, then oral anticoagulation is indicated. So in terms of what are these factors, so having congestive heart failure, hypertension. If you're over the age of 75, you score 2 points. And they've also got a bracket of if you're aged between 65 to 74, you score 1 point. Diabetes scores you a point. Having a previous stroke or TIA or thromboembolism actually scores you 2 points. Any evidence of vascular disease scores you a point, and being a woman scores you a point. In terms of the oral anticoagulation that's available, so in the past there was only one choice really. There was just warfarin, which is a vitamin K antagonist. However, due to the fact that there was a lot of variability with warfarin, there's a lot of drug food interactions. It's quite inconvenient for patients having they need to have INR monitoring because it needs to be within a therapeutic range to have its efficacy. And because of all of these things, there came a need to develop newer agents, and that's where these NOACs came along, and they are medications which have a fairly stable profile, They're quite convenient to use. You don't need to have INR monitoring. And previously, they were called the NOACs. They were called the novel oral anticoagulants, but because they've been around for some time now, they've changed that to non-vitamin K oral anticoagulants. There are two types. There's the direct thrombin inhibitor, which is dabigatran. That was the first to come onto market. And then soon after, there were further anticoagulants by way of factor 10A inhibitors, rivaroxaban, apixaban, and now edoxaban. All of these have been approved in the UK to use. And if we go to look at the clotting cascade, so they work in a slightly different way. So, you've got the extrinsic, intrinsic, and the common pathway. And warfarin, it's a vitamin K antagonist, so it inhibits the production of factor 7, factor 9, factor 2, and factor 10. It takes a long time to have its effect. Whereas these newer drugs, so for example, dabigatran here, it is a direct thrombin 2A inhibitor, so it inhibits the common pathway there towards the end. And rivaroxaban, adixaban, and edoxaban, they are factor 10A inhibitors, and so they have their effects here in this part of the pathway. They come at different doses. The standard dose and a lower dose. The lower dose is really for patients who are at higher bleeding risk. And in some cases, people who have renal impairment as well, they would tend to use a lower dose. To be honest with you, there's not much difference between them, broadly speaking, and they're all being found to be as effective as warfarin, if not some of them being found to be slightly more effective at stroke prevention. They've been studied in large randomized controlled trials with over 10,000 patients, and also the safety profile is pretty good. Particularly the lower doses, they have sort of lower risks of major bleeding. Now, talking about bleeding, obviously that's one of the main complications of long-term anticoagulation, and one of the tools that we can use to assess the patient's bleeding risk is the HAS-BLED, and it's quite a useful tool. It's got a number of points. Each of these points constitutes a risk factor for increasing your bleeding risk. So, for example, you've got hypertension, or if you've got labile INRs, or if you're taking certain drugs that increase your bleeding risk, like non-steroidal anti-inflammatories, for example. All of these, can you can assess for these things, and you can get a score, and it can identify those patients who are at a higher bleeding risk that may benefit from the lower doses of the NOACs, for example. But really, the way that these scores were designed, and actually the way that they are recommended to be used, is not to exclude people from anticoagulation, but rather to identify reversible risk factors and to address them. So, for example, if you've got someone who's got high blood pressure, get the blood pressure better controlled. That reduces their risk down. If you've got somebody who has got is drinking alcohol or taking non-steroidal anti-inflammatories, you can get them to and advise them to stop that. So it really is it's mainly as a tool for physicians to remind us of what are the factors that increase the risk of bleeding, and to remind us to do something about them to try to minimize that risk. So that's stroke prevention. In terms of whether to go for rate versus rhythm control, so the important thing to note is that there's been large studies that have shown that there is no prognostic difference between a rate control strategy, and a rhythm control strategy. Basically, you're not going to make patients live longer by getting them out of atrial fibrillation and into sinus rhythm, which is interesting. So then you start to question, well, what are the reasons for going for a rhythm control strategy? And I would suggest that actually uh, all patients should um, should be rate controlled, because you don't want people to be running around with heart rates of 140, 150 indefinitely, because they just that can cause it can cause LV systolic dysfunction. Actually, it can cause sort of cardiomyopathy. So really, everyone should have rate control, and this is in line with the sort of NICE guidelines. They suggest that rate control is first line, except for cases where you have reversible causes, such as whether you've got infection, or you have atrial fibrillation, for example, thyrotoxicosis, for example, in patients who've got new onset atrial fibrillation. And this makes sense because what we know about atrial fibrillation is that AF begets AF. So the more that you're in atrial fibrillation, the more it's it's like a vicious cycle. The more difficult it is to get out of AF. So if someone comes for the first time, it wouldn't be unreasonable to arrange for them to have a cardioversion, um, to try to attempt to get them back into sinus rhythm. Also, if they've got heart failure as a consequence of atrial fibrillation, then in those situations, it's better to go for a rhythm control strategy. In some cases, for example, atrial flutter, it may be worthwhile referring them for ablation procedures. Um, and so rhythm control really is mainly for people who failed rate control. In other words, they're still symptomatic. After having their rate adequately controlled, they still have symptoms. Also, rhythm strategies can be used in people who've got hemodynamic compromise, so they're unstable, so they need to have sort of urgent cardioversion. In terms of the drugs available for rate control, well, the mainstay really is beta blocker. And when we talk beta blockers, talk about the mainstream beta blockers like bisoprolol, atenolol, metoprolol, not sotalol. You've got calcium channel blockers. Of these, there are two types. There are rate limiting ones like diltiazem, and then there's also the non-rate limiting, like for example, amlodipine. Amlodipine wouldn't have any effect on rate control, so it wouldn't be used. And then thirdly, there's digoxin. According to the NICE guidelines, they recommend first line um, monotherapy, so beta blockers in most patients. But if, for example, they can't take a beta blocker for whatever reason, then you would go for a calcium channel blocker, and if not, digoxin. In terms of contraindications to beta blocker, well, in the past, people often were afraid to use them in patients with asthma or COPD, but actually, um, what we found is that in patients with COPD, there's been studies that have demonstrated that they looked at patients with COPD on beta blocker and compared to those with COPD not on a beta blocker, they found those patients with a COPD on a beta blocker, they had better outcomes. So they had improved mortality. So in fact, really, it's those patients who you've tried them on a beta blocker, but they can't tolerate it for whatever reason, side effects, or whether if they're truly asthmatic and they've got a wheeze related to it, then in which case you may want to try a calcium channel blocker instead. But I would always give them a trial of beta blocker. And a good one to use in patients with asthma or COPD is nebivolol. You start at a lower dose and work it up. Often in hospital setting, I have to say that digoxin is quite useful in the acute setting, particularly in patients who've got a bit of hypotension, and so you can't really give them a beta blocker. In which case, digoxin is quite a reasonable alternative. Um, However, for patients with atrial fibrillation, um, normally we use digoxin for patients with permanent atrial fibrillation, and it's better to use it in patients who are sedentary, because it doesn't seem to work very well when people are ambulatory. So usually we reserve them for the sedentary patients with permanent AF, and these are usually older patients. So that the first line is monotherapy, and the second line is a combination of two of them. I'll have to say I would be cautious about um, using beta blockers and calcium channel blockers uh, in patients. Um, I would probably reserve that for a cardiologist to decide, um, and particularly because sometimes when you start patients on beta blockers, particularly in hospital setting, it can take a bit of time for the beta blockers to have an effect. So sometimes people do rush in a bit too much and get a bit nervous that the heart rate hasn't fully settled. It tends to settle down. Okay, in terms of rhythm control, so the mainstay of rhythm control really is using pharmacological agents and electrical cardioversion. Uh, there are some patients who you can refer for AF ablation procedures. You can refer them to the electrophysiologists. However, these procedures they have a low chance of success, and often patients need to have more than one procedure. So there is some evidence to suggest that an early ablation strategy uh, is good for improving symptoms. So that might be something to consider. Um, but generally, we tend to reserve it for those patients where we've tried other means and they haven't worked. Um, there is a very drastic um, treatment for atrial fibrillation, um, and for this is called an AV node ablation, and you essentially render the patient in a state of complete heart block because you ablate the AV node. So whatever signals coming from the fibrillating atrium, nothing gets conducted down. And these patients would need to have a pacemaker put in. So again, this is not a first line. This is sort of the end of line once you've tried everything and there's the patients are still symptomatic, really poorly rate controlled atrial fibrillation despite optimal therapy. So, when it comes to cardioversion, it's very important um, that you do an echocardiogram for the patient for a number of reasons. Firstly, to look for any signs of structural heart disease, which is important in guiding choice of pharmacological agents, and also to look for any signs of LV systolic dysfunction, valvular heart disease, which would give a bit more weight for you to try cardioverting. Also, it's important to look at the left atrial diameter, just because the larger the left atrial diameter, the lower the chances of successful cardioversion. You can warn your patients about that. Um, to increase the chances of success, um, pharmacological agents should be used, and beta blockers are recommended as first line. So I'd start the patient on a beta blocker, tee them up for a cardioversion. If beta blocker is not effective or they can't tolerate it, then you've got a choice of either going with amiodarone in patients with structural heart disease. Although I'd be very cautious to put patients on this in the long term, but certainly for a short period of time, while to facilitate a cardioversion, it wouldn't be too unreasonable. Obviously, amiodarone has a lot of side effects. It can affect the liver, it can affect the thyroid, it can affect the lungs, it can cause fibrosis. It can cause photosensitivity in the skin, so patients have to avoid the sunlight. Um, so it is a drug that does have risks with it, and we want patients to be on that long term, unless it was absolutely necessary. In patients who don't have any structural heart disease or ischemic heart disease, you could try some of the other agents, such as flecainide or sotalol. But again, all of these agents, they do carry risks with them. They have pro-arrhythmic risks, and they can also prolong the QT interval. So it's important to look out for that. Dronedarone is an interesting drug. It is a drug that was designed, pharmacologically designed to be similar. It's very similar to amiodarone. However, it's has a shorter half life, and it's designed to not have the the, uh, the complications associated with amiodarone. So from that perspective, it was successful. Certainly does not have the same complications as amiodarone. However, it's not as effective as an antiarrhythmic. Um, and there's some early studies were very promising, and in fact, they were put into the recommendations for the guidelines for the use of dronedarone. However, there were some studies that showed there were some caveats. There was some increased risk found in patients who've got permanent atrial fibrillation and also in patients who've developed heart failure. So dronedarone can be used in patients who have paroxysmal or persistent atrial fibrillation for short-term use, as long as they don't have any evidence of heart failure. So in terms of cardioversion strategy, so if the patient presents with symptoms of an onset of atrial fibrillation within 48 hours, then you can really go ahead with an immediate cardioversion. Following which you would start, assess the patients and start them on anticoagulation. However, if the patient has an onset of more than 48 hours, then it's recommended to delay the cardioversion. The reason for this is that patients with atrial fibrillation can develop left atrial thrombus, and left atrial thrombus, when the patient is cardioverted to sinus rhythm, that can dislodge and increase the risk of stroke and thromboembolism. So therefore, you would need to ensure the patient has adequate anticoagulation for a period of about 3 to 4 weeks without any interruption in anticoagulation before you would do a cardioversion. However, if you have access to transesophageal echocardiography, then you can do an early TOE guided cardioversion where you can perform a transesophageal echocardiogram to look at the left atrial appendage in particular, because that's usually where the thrombuses are found. And once you've excluded a thrombus, then the patient is safe to undergo electrical cardioversion. So how do you go about cardioverting a patient? Well, there's a number of things that you need to. These are the main steps involved. First, you need to check that the patient is nil by mouth and has been nil by mouth for a period of time, around 6 hours, and this is because of the risk of aspiration when you sedate the patient, or if you anaesthetize the patient. Secondly, you need to check that the patient is adequately anticoagulated, and again, as I mentioned, you'd want them to be anticoagulated for 4 weeks without any interruption in anticoagulation, and it has to be therapeutic INR. So, for example, if they're on warfarin, you need to make sure they've had therapeutic INRs for at least 4 weeks. If they're on one of the newer agents, the NOACs, then you would need to confirm with the patient that they haven't missed a dose. A number of ways you can do that. You can ask the patient. Secondly, you can count the pills. You can get them to bring their box of pills, and you can actually count them to see whether there's the right number of pills available. You want to do a couple of pre-procedural checks. You want to have a look at the echocardiogram, have a look at the signs of LV systolic dysfunction, look at the size of the left atrium, for example, whether they've got any valvular heart disease, etc. You'd want to make sure they've had their thyroid function checked, and if it was abnormal, get it corrected before you do cardioversion. Similarly, with electrolytes, make sure that the potassium, magnesium, etc. Are more satisfactory, because otherwise, if they've got electrolyte abnormalities and they've got thyroid dysfunction, then the chances of successful cardioversion are pretty minimal. Then you consent the patient, explain to them the risks and the benefits, and get them. Ideally, you'd get them to sign a written consent form, and then you'd need to anaesthetize or sedate the patient. Now you can do this in a number of ways. You can either get the anaesthetist down, or arrange it to be done in theatre with an anaesthetist who puts the patient under a general anaesthetic for for a short period of time. Remember, you need to consent them for this as well, and warn them about the risks associated with that. Or in some places, they tend to use sedation with agents like, for example, midazolam. Give midazolam and check that the patient is quite heavily sedated before you give them a shock. Then you get them all monitored up. You attach the pads, and as you can see here, you put the pads in an anterior posterior position. You can also put the pads on the front and back of the heart, particularly on the back, particularly if patients have had pacemakers. If they've got pacemakers, then you'd want to avoid the pacemaker site. Once you've attached the pads, very, very important is to press the synchronize button. So first of all, you need to be familiarize yourself with your local defibrillator, and they come in different shapes and sizes. Familiarize yourself with it, and what you'll find is that there'll be a screen for you, with the rhythm. You want to press the synchronize button. It's very important when you're doing atrial fibrillation or atrial flutter cardioversions. That way, that synchronizes it so that when the shock is given, it's not given it's given in the correct time. Otherwise, you could cause ventricular fibrillation. You set your energy level, and again, different hospitals have different policies. Some start at 150, some start at 200, some people start at 360 joules, some people work the way up, start low, work the way up, some people do it high. And once you've set the energy, check the rhythm on the monitor, make sure that the oxygen is away from the patient, press the charge button until it's charged, and then you deliver the shock. Just before you deliver the shock, always check the rhythm on the monitor one last time, just to make sure the patient is still in atrial fibrillation before you give the shock. So then you give them the shock, and you can repeat this process up to a maximum of 3 times, really. If you haven't cardioverted like 3 times after 3 shocks, then really there's little chance of success at that time. In which case you just you'd stop the procedure, abandon it, explain to the patient it was unsuccessful, and then you may need to think about you may want to repeat the cardioversion at a later date, but with other antiarrhythmics on board. For example, you may want to add in amiodarone, for example, and then you would do an ECG immediately afterwards to document that there is sinus rhythm, and then you bring the patient back about 4 weeks' time, 4 to 6 weeks' time, where you would repeat the ECG and check to see whether they've maintained sinus rhythm. I have to say, generally speaking, most cardioversions are pretty successful at the time of the cardioversion, but usually looking at around 40 to 50% recurrence of AF on follow-up. So the other important thing is, as I mentioned before, if the patient has had the onset of atrial fibrillation for more than 48 hours, then you could arrange a TOE if you have access to that, and that way you wouldn't need to delay the procedure for 4 weeks. The other important thing is always do a pre-cardioversion ECG because the patient might be in sinus rhythm. So there's no point going through all of this and then right at the end finding that they're already in sinus rhythm. So there is another approach that can be used in a group of patients. This is They call this the pill in the pocket approach. So what that means is that the patient carries around with them some pills, and when they get their episode of or the paroxysmal atrial fibrillation, they can just take one or two of the pills, and then that would cardiovert them. So this is usually quite a successful strategy in sort of younger patients, those who are not very keen to be on long-term medications, and those patients who've got sort of infrequent paroxysms of atrial fibrillation. They may get these paroxysms every 6 months or every year, something like that. And so you give them beta blocker or flecainide or sotalol, whatever choice of antiarrhythmic. When they get their paroxysm atrial fibrillation, they can just take a couple of doses of that. Um, and if they're still symptomatic, then they could go into hospital. So it's quite a useful strategy. It avoids multiple hospital admissions, and it can avoid the need for long-term medications. Okay, so the last feature or the last aspect of the management of atrial fibrillation is to look at any concomitant disorders or any precipitating factors. So you check for electrolytes, abnormalities, and correct them as appropriate. Look for signs of any infection, treat that. Similarly, they may have ischemia. Be having a myocardial infarction with associated atrial fibrillation. So you'd want to address that and treat that. Um, they may have concomitant heart failure, so you'd need to assess that. Make sure if they've got fluid overload, make sure you put them on diuretics to maintain the normal fluid status, and treat their heart failure appropriately. So often you'll find in a hospital setting that patients will develop atrial fibrillation following an operation. It's very common. Often you'll find that these patients, they don't tend to remain in atrial fibrillation. Usually just quite self-limiting. Um, Certainly by the time you follow them up, maybe in a few months' time, then they would have been back into sinus rhythm. But again, if needed, you might need to give something for rate control in the acute setting. I would just be quite wary of. As I mentioned before, digoxin is quite a good drug to use in patients in hospital setting, particularly if they've got hypotension or through any sort of hemodynamic instability from other causes. But I would just be very careful to discharge patients on digoxin. I would make sure you review their medications on discharge. A beta blocker, by that time, if they were hypotensive, then by that time they should no longer be hypotensive, and you may be better off up titrating their beta blocker to get rate control and stopping digoxin altogether. Yeah, you check thyroid function, address any thyrotoxicosis. Similarly, if they've got any cardiovascular risk factors, you want to control them. Make sure they've got good blood pressure, glucose control. Check their lipids. Advise them to increase their physical activity and lose weight, if, for example, if they're overweight. Okay, so in summary, what I've gone through today is gone through some definitions of some important definitions for atrial fibrillation, in particular the terminology paroxysmal, persistent, and permanent. I've explained about the diagnosis of atrial fibrillation and that in patients who have a high index of suspicion, you would need to have more prolonged monitoring. I've gone through stroke prevention and the importance of stroke risk assessment using the CHAS-VASc score, as well as assessing the bleeding risk and addressing any factors that can be controlled. I've mentioned about anticoagulation with warfarin and the non-vitamin K oral anticoagulants. I've also gone through a rate versus rhythm strategy and how to decide, and that in fact patients should, on the whole, be managed using rate control with either beta blockers, calcium channel blockers, digoxin, or a combination of these. I mentioned about rhythm control strategy, which is essentially electrical cardioversion with pharmacological agents, possible role of ablation in certain patients, and how rhythm control really is useful in patients who failed the rate control strategy. In other words, they're still symptomatic despite having adequate rate control. Also, patients who've got heart failure or any patients who've got hemodynamic instability. And lastly, I mentioned about the importance of looking for and addressing and treating any concomitant or precipitating disorders. I hope that you've enjoyed this talk and that it was beneficial. And I invite you to check out some of the AF scenarios in another video where you can test out whether or not what you've learned. And lastly, there will be some further talks, particularly about the novel or the non-vitamin K or anticoagulants, the NOACs. So check that video out as well.